So I wanted to welcome everybody to another segment of Soffer Longevity. This podcast is going to focus on some of the cardiovascular things that are swirling around the internet that people really want to know more about, how to both live better and live longer. And for that, I, again, have our very special guest, really co-host at this point, Dr. Safa Maklad. Welcome, Safa.
It's nice to be here again.
So tell me, I know you had come up to me, and the idea of this podcast really has been like, two of us are sitting at the doctor's lounge eating some probably really crappy refried beans, whatever they serve us. And we are talking about some of the events of the day, whether it's patients or news. But you had asked me an interesting question on the cardiovascular side. And so I wanted to sort of start with that today.
Well, it's an awesome opportunity that I actually get to sit with a world-renowned cardiologist and ask whatever questions I want. So
can't wait for him to come in, but go ahead.
So it's going over cholesterol and just going over the different things and what your perspective is on it.
Yeah. Well, as a functional medicine specialist and a sort of a traditional cardiovascular disease specialist, that's where my board certification has come from. 30 years ago, every 10 years we have to take a repeat exam, so it's up to date. But as a cardiovascular doctor, it's a little bit different than a functional medicine doctor, because a functional medicine doctor is, like yourself, really looks at some of the root causes, like the diet and the exercise. And that is entirely true. There is a big component of diet and exercise and sort of lifestyle decisions that we make that affect cholesterol. But there's also the parents that we choose.
Yes.
Right. So genetics play
Quite the role.
Huge role.
Yeah.
And it's something that I've known for a long time. Specifically that diet in particular is only so helpful. We found like in the most stringent diets that it helps 10 or 15% of your cholesterol numbers. So if you're just on the borderline and you want to try some, good Mediterranean style diet or, the various diets that are out there to lower cholesterol, then great. But most of the times when people come to see me, they need much bigger reductions. Yes. And I say, listen, try it for a period of time diet because I want it to work. I wrote a book on the Mediterranean diet. I strongly believe in it. But to be able to overcome genetics, it's really hard sometimes. So the things we're going to talk about today are things like Lp(a), which is a new biomarker that talks specifically about did you or did you not get genetics that are going to play a role? And ApoB, which really helps with our LDL cholesterol, our good and bad cholesterol numbers, to get an idea of who we need to act aggressively with from usually a pharmacological perspective. So with that, I'll kind of punt it back to you for a second and ask you, when someone comes to you, for early cholesterol management, early, I should say, atherosclerosis prevention.
Yes.
How do you first look at it typically?
So in the beginning, I usually order all that. So the ApoB, lipoprotein A, in addition to the regular lipid panel. So I'm usually catching them way early because their normal cholesterol panel probably wouldn't have been elevated at that point in time. So yeah, a long time before they come to see you.
So would you say that's really the difference between your specialty and our specialty is that you're like pre-prevention. You're like your prevention is like, to put it a different way, it's like next level. It's like you're really trying to get them
before anything happens.
And tell me more about these studies, and are they covered by insurance?
That is the problem, is that a lot of the time it's not covered by insurance because their lipid panels are within normal limits. So that's where you kind of come into you're not able to order those advanced tested through insurance. So we order it outside of insurance.
Right. So let's talk about that for a second, the normal levels. That's something you and I have talked about both at our little doctor's lounge here as well as, professionally, in that you as my doctor saw I had some normal levels, say my hemoglobin A1C, my glucose levels, that were normal, but they weren't making me happy, because out of the normal level, it's a brig. You have your various color areas, your green and your red, yellow. But the normal in my case was in the green, but it was on the part of the green that suggested to me I was graphing towards maybe having some problems in the future.
And then that's when we add those additional tests, like seeing what your insulin level was, having you wear the CGM, checking your homocysteine.
Continuous glucose monitor.
Yeah, the continuous glucose monitor. So all those things are like pieces of the puzzle that we can put together to say exactly what your risk is, instead of just looking at that single number and saying, oh, you're fine.
Right. So people that get normal levels now, normal levels maybe 20 years ago were, first of all, we've made them more stringent. Cholesterol has come way down. But normal levels in general now have varying degrees of normal. So you can come out and get your doctor to tell you, well, your tests came out normal, but how normal?
Yes.
Because we know one thing for sure. The three major diseases that kill us, that make us older, that take our life, shorten our lives, are cardiovascular disease, in this order, cancer, and neurodegenerative diseases, right? So all three of them, from what I've understood, take somewhere between 20 and 25 years to develop. They don't really happen overnight typically, right? So this idea of like, you want to find the normal that's on its way to becoming abnormal, not waiting for it to be borderline. So many times I'll hear a diabetic or pre-diabetic, I'm almost diabetic. I'm just before diabetes. Well, that's our time to act, right? That's when they need to see you.
Like I had a 19-year-old. So hemoglobin A1C was completely normal at 5.3. I mean, it falls into that normal range, but her insulin level is 49. So that's very high. I mean, normal, you would like to see it between 5 and 7. So insulin resistant, and she was on that path. So if we didn't catch her, now at 30, 40, then you start seeing the hemoglobin A1C rise and then having the subsequent effects of that.
So it's almost like your specialty of functional medicine is kind of like trying to dissect the normals from those that are normal now but on their way.
Yes, yeah. Because you want them optimal. You want these optimal levels, not necessarily normal levels.
Right. I think that's maybe the better word. It shouldn't be green. It should be optimal. So I know I saw it when we did all of my advanced testing and things that I thought were normal, felt good about it. I was like, I don't know if I love this trend. Which the word trend actually is very important here because unless we're able to do, like for those of you who are watching, not necessarily listening, I'm holding up the book about you, which we have in our longevity program, but a lot of others are trying to incorporate this idea of graphing all the information or amalgamating, putting them all together, and then watching them over time. Because any one time, any moment can be unsatisfactory. In other words, you could have a cholesterol even cholesterol can change because of maybe sometimes some stress or some recent viral illness or things like that. So a point in time is not as helpful as a trend. And if your trend's going in the wrong direction, that's when we have all these treatments that we
want to intervene. Yeah, at that point. So, and then that's when it's actually most helpful for diet and exercise at those points in time before you're actually diagnosed with a disease.
Yeah. So getting the trends down is extremely important. This company that we've been working with, this longevity AI company, has been able to capture not only a lot of the data from the existing patient's traditional medicine, but adding in all these new functional medicine or longevity medicine data points like that you've been getting, the advanced blood testing, the advanced imaging, things like that, putting them together. And then they have their own database of millions of patient lives that they've kind of combined to really give you this kind of snapshot of where you are, where you've been, where you're going against where other people with similar scenarios, giving you a risk analysis that is 21st century and not...
And your biologic age instead of, compared to your chronologic age.
Right. So we wanted to focus today a bit on the cardiovascular side. So one of the interesting things that came out recently at the big heart meeting was that we're shifting from what is called what used to be called the Framingham Heart sort of score, which was done in a place in Massachusetts,
Yes.
Framingham.
Drove through it many times.
Yeah. And I was actually, when I was in my training in the 90s, that was already kind of old data. So I think it's from the 70s. And that has actually set up our risk platforms for cholesterol, which is why when I was originally training, a cholesterol of 200 was like borderline. Now it's probably much less than that. Probably it's definitely much less than that. So we learned a lot during those times. But the Framingham Heart Score has recently been, I don't know if it's fully replaced, but there's a new score called the Prevent score. And the Prevent score adds new dimensions, things like calcium scores, ApoB, these things that we're talking, these advanced modalities that you and I talk about all the time, that weren't used for the Framingham score. So that's now in the Prevent. And then companies like Longevity AI are amalgamating all sorts of data that they're getting from multicultural perspectives. So it's not just from, one of the old things they used to give us a hard time with in Framingham was like, it was just white
males.
men, right? And so how did white male genetics apply to
everybody,
female African Americans or whatever it is? So now with these new companies that are coming up that are amalgamating, putting all the data together, I think we have a better idea of what a person's individual biologic age is, and that's something that I think the two things we chose to discuss earlier, which was ApoB and Lp(a). So just again, I don't know if I said it perfectly or not, but Lp(a) tells you about your genetic preponderance. So it's not something that you're eating 90+% of the time. It just your genes are making a type of particle that puts you at increased risk. And it's nothing you did, ate, or you didn't sleep well. It's not about that. It's mostly, it's telling you only really need that kind of done once to know that you have an increased risk factor. You got the genes from your parents, most likely. You can have spontaneous mutations, but most likely you got it from your parents. And you can actually go one step further and check your actual genes, the DNA of the genes, and there's a whole bunch of genes that are related. And then you can get your siblings and first-degree relatives tested. So not only is it good for you to test, but it could save someone in your family. So I suggest everybody to get an Lp(a).
Is it covered now?
Probably not.
Okay.
But it's probably on its way because with the Prevent trial and so forth, it's getting easier. But it's not expensive. And in a good longevity office, it's routine. And there are treatments. So if you get an Lp(a) and you find it to be elevated, I'm not going to mention the numbers here because there's a difference between nanomoles and milligrams. And if it's elevated and to varying degrees of elevation, guess what? At that point, you get more intensive treatments that we have. So you will be, kind of pushed into a little more aggressive, usually pharmacotherapy. And there are drugs that I happen to be a principal investigator on, so I won't mention, but it's one of the major companies out there, and they're doing drugs specifically targeted for Lp(a), which will be, in my opinion, game changers. We'll no longer just have sort of statins and the current non-statin therapies. We're going to have a whole new class of drugs that will be for Lp(a), meaning you got the genes from your parents. Here's
lower it.
Basically, let's. I don't want to say the antidote. That's too much, but it'll be a major treatment for that. So you won't have to have the destiny that your parents had, and you may be able to live a bunch longer and better. So that would be with Lp(a). ApoB, a little bit different, a little more affected by diet and lifestyle, which means you can treat it with the things that you strongly recommend and look after, the diet and the lifestyle. And then we have some drugs already for it, the PCSK9 inhibitors, particularly the Repafas.
They work really well.
Work really well for it as well as general cholesterol. But it's complicated. You got to take it all together, get yourself a book of you, or at least understand all of your lipids and take it. So let me ask you this. So if a patient came to you and they came with high cholesterol but no other symptoms, what's the first thing you do these days? Or what's the first?
The first thing is definitely diet, and then also trying to get them to exercise. That's just kind of the foundation for everything. But then we check other things to, what is their vitamin status, what are their mineral status, what else what else is that the body's missing that we can supplement to help them kind of move into the right direction. And interesting enough, like if you start to get their homocysteine level down, the cholesterol kind of tends to lower a little bit.
Yeah.
It's not a lot, but
Yeah.
but at least it's kind of helping in the right direction.
Yeah, and so many people want that. They want to try first the functional medicine ways, the more holistic ways. So, following, I'm
The
assuming
Mediterranean diet is like amazing. And
Mediterranean diet was
intermittent
one.
fasting.
Intermittent fasting, another one, to help their overall cholesterol for HDL, more sort of fish oils.
Yes. The
omegas
the omega-3 supplements. Yes.
can help with HDL. So we're still learning on the ApoB and the Lp(a), but it seems like all of those things kind of help together. It's really not a one size fits all.
No, not at all. And some of them just need the medication. Like some people get placed on Repatha just because no matter what they do, that number just...
And Repatha is the most common injectable, right? It's the one that you get one injection. It can be as little as once a month. It could be, or inclisiran, which is another form of a PCSK9, which would be once every 6 months.
Yeah, which is... Yeah.
And if you can imagine that can change your cholesterol. It can really basically sort of figuratively change who your parents or what genes you got from your parents by getting one shot once every 6 months. It's amazing. We don't do as much of that because that drug is a little newer and a little more expensive. But the once a month thing is pretty great with Repatha. Once every couple of weeks, depending on how much you need it. And very specific. So you check your ApoB in that situation, and if it were high, and even with a normal LDL, you bring down your ApoB, and boom, you should know at that moment that you're going to have less risk of heart attack, less risk of stroke, and all of these studies are really showing that we're doing something, which is something that you and I want to sit in our little doctor's lounge and feel good about. Hey, we not only diagnose something with some blood labs and some testing, but we're able to implement a treatment and then show that the treatment helped the blood labs.
Yes.
And then we know over time, because we have enough patients to know less. I mean, I can't even tell you the last time we saw a heart attack or stroke in our practice. I'm not saying that it doesn't happen. I'm just saying that, like, when you take a preventive approach, you see much less of it.
Yes, definitely. What are your thoughts about doing the coronary calcium score and all that on
that type of imaging,
especially with somebody with an LP little a that's
so
elevated?
I was blessed. I actually trained with the guy who invented it. It was a guy by the name of Arthur Agatston. It's actually called the Agatston score.
Okay,
and
that's okay. I did see that name, and I'm
the Agatston score. So Arthur is a friend of mine for many years, and I trained with him in the mid '90s, and it's one of those things that I don't even think he knew how big of a deal was going to be. We're seeing a bit of calcium on a CAT scan was going to be a surrogate marker for growing atherosclerosis, or at least the likelihood that you have building up of harder arteries, right?
Yeah.
So that is a correlator, and it is one of those things that helps us to convince a patient. We usually kind of know by other markers, but it's nice to be able to say, okay, your calcium score either is elevated, we got to get to work, or was normal and now is elevating, which is even more psychologically beneficial for a patient to start down the pathway of being on the right medications or extreme diet changes, which is
it's very hard,
less likely. But we've seen with the GLP-1s in diet that sometimes that is all you need. In fact, the peptides that we know, the most important peptide in the world right now, the GLP-1s, the Ozempics and the Mounjaros and whatnot, are with diet, super useful for cholesterol, including some of the subfractionations that we talked about, the other elements.
Because I think that is more kind of metabolically, like insulin resistance kind of driven for their cholesterol to be elevated. And so once you control that, I think the cholesterol just follows.
I think insulin's definitely a part of it, but we've found there are reasons we don't even know. Like even people with the same insulin resistance levels and so forth, they still have less heart attacks, strokes. They still have benefits of like less Alzheimer's and things that we're just wrapping our head around.
Could it be the anti-inflammatory effects of it?
Exactly, this inflammation scenario that we seem to be sort of slowing down inflammaging type of aging. Well, you and I totally agree on that one. I'm a huge proponent of it in selected cases, and one of the biggest things that we talk about at Soffer Longevity and in our lounge here is that every single patient is a little bit different.
Yes.
And we cannot treat patients as populations, even though companies like, these data aggregators like Longevity AI and similar give you lots of population data. They got to make it for you in a way that is then digestible for us and the individual patient.
Yes.
So one of the things that I've found with, in particular, the GLP-1s is not who to put on. It seems pretty obvious who to put on. That has been expanding for me. Initially, it was just people that were morbidly obese, then just obese, then just kind of overweight, then just maybe a little bit weight, and then even like somebody who's skinny fat, and that maybe has some visceral fat or something would benefit from it, or maybe even someone that has sleep apnea alone seems to be benefit. Okay, but we've broadened that. That's not the problem that I'm feeling right now. The problem that I'm feeling that here we can talk about at the doctor's lounge, our little cool doctor's lounge, is how to get off it. So there's a couple of problems. We talked about this in one of the other episodes where when you get off it, if you get off it abruptly, you form a risk of almost like a rebound where all that stuff you were saving from, whether it's heart disease or stroke, bumps up during the period afterwards when you start not just regaining weight, but the inflammation, the anti-inflammatory response goes away. So there's this increased risk during that time frame. As well as people gain that darn weight, which is depressing. And so that is right now the big topic of debate. Do you wean? Do you microdose? Have you changed behavior enough? Subject maybe for a full podcast. But one of the things I read today, because I like to talk about sometimes the interesting things that come across today, but just today I read for something that was a couple of days ago. There's a thing called duodenal modification, something or other. I think it's called DMR. And what it does is it's being proposed as a mechanism of getting people off of the GLP-1s. So once you've lost the weight, they kind of cauterize, or they warm up a bit of the duodenum through an upper GI scope, and apparently that maybe the cells there that get I guess maybe burnt or cauterized might be a little heavy, but it's I believe it's thermal. And this was done at Dartmouth, and I saw something else I think at UCLA. So this is real studies. Dozens, not hundreds or thousands yet. But they were doing to these folks that had just lost a certain amount of weight, and they blinded them to sham procedures where they didn't do it. And everyone that had that DMR, I think it's called, that had this duodenal procedure kept the weight off, and they don't even have a time where it stopped. So there has been a lot of interesting stuff lately about, as we were talking about, getting off of the GLP-1s, which is everything from microdosing to the duodenal procedure that may be helpful and, maybe mimicking what the body is feeling when taking a GLP-1. So this kind of feedback loop between the GLP-1 receptors, maybe the vagus nerve. We're really not sure exactly how it works so well, but we know it's probably the brain gut axis. So figuring out how to get off of it is key for me. It was very important to intermittent fast, and for that I stopped eating around 8 o'clock. Usually a little sooner. I like to give myself at least 3 hours before I go to sleep and not eat. I think that's important cardiovascularly. I think it's important from an insulin sensitivity perspective. And for me, it's from a digestive perspective and just sleeping well. And then I would basically skip breakfast. I would have some caffeine, usually in the form of coffee in the morning. I'm a strong believer in the parasympathetic-sympathetic balance, which is, again, another episode. But in the morning, you need sympathetic. You need to have like the, sunlight, and you need to kind of, wake up in a proper way, not too abruptly, but in a proper way. And I think that the caffeine and adequate hydration is important. And then I started eating at noon. So that's my 16-8 fast. And it worked for me to keep the weight off that I did lose during my period of GLP-1s, which was like 3 years ago. That being said, still got to think about it. And I sometimes see the train going the wrong direction. And I feel like sometimes that if I start to gain a couple of pounds, maybe I could do a longer fast, but I know you just did one of those. So maybe if you could tell everyone about what I think is Herculean in your 5-day fast recently. So today's segment is sponsored by Longevity AI and a book about you, which is their incredible data aggregator that gives you information about yourself, combines it with the traditional medical as well as the longevity testing that is now available, puts it into a graphical way that really gives you a great idea as to where you are, and there's an app that goes with it. So ask your doctor if they're using Longevity AI, which helps to amalgamate all the data around your traditional medical and longevity medicine, put it into one place, and see if you can get a book about you. And in an effort to kind of democratize all the information that we're gaining now about longevity, I want to keep this podcast free. I want to keep it unbiased. So we will periodically have sponsors that really are in a position not to bias us, but we believe in and that we think, particularly Longevity AI, that may have the key to really adding the artificial intelligence with the human touch into the patient's medical record like never before. And I am excited to have them as our sponsor and look forward to many more episodes that combine artificial intelligence and human longevity for the benefit of all of us, free to everyone. So I thank them and I thank you for watching.
So did it last week. And so, it was a 5-day fast, but
I stayed away from you on day 2.
Yes. Day 2 and kind of day 3. I did a modified. So it wasn't just water. I allowed myself liquid. So it was mostly bone broth and
so
teas.
Indulgent.
And yes.
All the bone broth.
All the bone broth I wanted.
Okay.
And went through the 5 days. And the first day wasn't bad. Second day was a little harder. Third day, I was like, I think I'm hungry. But then after that, it was fine. Day 4, day 5, I felt awesome.
Yeah, I talked to you all through it, but day 5, you seemed like spot on. You were happy and cheery and didn't seem hungry. And
at all.
I think I ate a donut in front
You
of
did.
You. But a really good donut, too.
And the weird thing is I had no
interest.
No interest at all. Yeah, it was kind of like, okay.
How was dinner that night?
Dinner, I actually ate pretty light. I went to a place that Ty recommended, so that was
Ty's our manager.
Yes.
She's not being ethnically incorrect.
Yes, no. Just so I had a light dinner, and the next morning, I thought I was gonna, wake up and want breakfast, and not really. So I didn't eat until dinner the next day.
So it took you a while to kind of. Are you back on?
I'm still at that once a day kind of eating. Yeah, so
it changed something in
did change something,
in your mind a little bit. Have you done this before?
I've done it once before. The time before I actually did was just a complete water fast. So that was
harder.
Definitely harder. Yeah.
Why? Because the bone broth?
The bone broth actually, it's warm, it's filling, and you get the electrolytes and other stuff, so you don't feel as...
Interesting. Mm-hmm. So let's start with this. Mm-hmm. Why did you do it?
I felt like I needed a reset. So it needed my GI tract to finally clear out everything that was there because the couple of weeks before this fast, my sister and my dad were here, so I ate with them a lot.
I see. Interesting. So you felt you needed a reset. You weren't sick. You just felt like maybe you were too indulgent in something and sluggish. And so you did it. And you feel now how?
I feel great. It's the thing that I noticed the most is actually the sleep. So I was sleeping like all through the night, where prior I was like waking up a couple of times, just, I don't know why I was waking up, but I was just kind of waking up and then trying to go fall back asleep again. But over that, I started noticing it on day 2.
And even now that you've reintroduced eating, you're still sleeping through the night.
Still sleeping through the night.
Amazing.
So something changed.
Yeah, because we know from a cardiovascular perspective, maybe one of the most important things, if not the most important thing, can be adequate sleep.
Yes.
And it's not just sleep duration, it's sleep quality. All of it is trackable now. One of the big things that you and I are big proponents of and seeing a lot of is everyone wearing the Whoops or the eye watches and Apple watches and Garmin's, whatever, all these wearables, these wearables and the biometric data that's coming in.
You even have your bed.
Yeah, my bed itself it's got a full HRV / rapid eye. I don't know how it does it, but it comes with a lot of great information on my particular bed. But all this information now goes into my book of me, book about you. Longevity AI has it, but the way that we do it, and I can graph it, so I know how I'm doing, maybe in stressful periods or not. Yes. I also did the continuous glucose monitoring, which again, we want to stay on the cardiovascular path today, but that is, when I was cardiovascularly exercising, I watched my what exercise worked best for me. Was it, was it zone 2? Was it HIIT type exercising, high intensity? Was it low intensity? And so I got an idea of me. And that's the most important thing that I think that we like talking about is the individualization of what we do. It cannot be done by population. It cannot be done by an AI computer alone. These AI devices are designed to help us. They're not designed to be alone. There's one of my favorite academic clinicians, doctors, is a guy named Eric Topol. He wrote Super Agers, a bestseller, terrific. He was the chief over the Cleveland Clinic for many years. And the bottom line is that he wrote an article last week that talked about how important AI is, particularly data aggregation that is coming and the administrative tasks that it does, graphing things, getting people to understand what they're doing, answering patients' questions, but not instead of a doctor. They're just enhancing the doctor, and maybe forever will enhance the doctor because we have to synthesize so many pieces of information and then take that population, that computerized data and say, okay, I'm looking right at you and, your blood pressure's high, but, you were at a big party last night and maybe that's, let's bring you in tomorrow. Or, you had a little bit of high cholesterol, but there was a reason for it. Or little things that it'd be hard for a computer to ever fully understand, but that the human touch can make such a difference. So it means that we all believe in AI, but it has to be managed by humans. There are some things that don't, though. So there is I think the whole AI medical industry has been led by the retina, the back of the eyes.
Oh, yeah.
So you could take a picture of the back of the eye right now and learn what a person's likelihood of potentially for Alzheimer's. Are doing that in China.
Parkinson's.
Oh, yeah, it's just obviously any vascular disorder, hypertension, heart disease, stroke risks. So it tells you so much, but that is actually done better by computers than by humans because of the pattern recognition. So images and pattern recognition seem to be done better by computers, but they still then have to go to a human caring doctor's perspective and individualized. I want to say the word caring, but caring means caring for the individual, not just being empathetic or kind, but like focusing in on that individual, taking all that bit of information, putting it down somewhere where you can access it, and then caring and turning it into that individual person's perspective and what's good for them, because what may be good for them at 30 may not be at 85. What may be good for a particular type of person may not be for their spouse or whatever. And so that's where I think we're at here in the cardiovascular realm, is really individualizing everything, getting all this information, putting it together, understanding it, and giving it to that person so they can, get maximum longevity, so better, longer.
Yes. And you meet them where they are at that point. Yeah.
Yeah, and that's the essence, I think, of your specialty as a functional medicine specialist. So I think we've covered quite a bit in the cardiovascular realm. Maybe the one thing we didn't really talk about is this advanced testing called CTAs. I'll talk about that real quickly. We offer it, in the Soffer Longevity practice, but it's a special CAT scan that is, it started kind of out with that Arthur Agatston calcium scoring, but then that's just the bits of calcium that we see around the coronary arteries, which tells us, are you laying down plaque? But now we have an advanced form where we can actually put a little dye and in minutes get an idea of exactly what the coronary arteries look like, similar to an angiogram. It's basically similar to a non-invasive angiogram. So you're not putting any tubes in the arteries, you're not doing stents, you're just looking. But in a few minutes with computers, you can get a three-dimensional structure that looks like the heart and the heart arteries. And that can tell you not only now whether or not you have blockages and how much, with a great degree of accuracy, but also the soft plaques that you could never see before. So how many of those plaques are vulnerable to break open and go from 20 to 100 and kill you? Because that's the most likely reason to have a heart attack these days, is not the 90% lesion. It's the 20% that pops open like a pimple and closes up abruptly and doesn't give the body time to kind of make new arteries, and that's where we get heart attacks. And so in the end, the CTA is something we order a lot. I'm going to have one, even though I'm asymptomatic, with great numbers. It's
still to take a look.
Still want to know where do I have a vulnerable plaque? And if so, maybe I need to be a little more aggressive in some of the things that I'm doing. So I love the CTA from a cardiovascular perspective. I think it's probably the biggest advance in cardiology over the last decade. And
I had a patient that was he's 44, picture of health, and CTA was abnormal. So you find things.
You find things, and then you can do something about them. Because in the old days, we could find things, maybe not do something, or sometimes you want to do something, but you need something to push you over the edge to really be able to objectify it and watch it over time. Because the nice thing about CTA, let's say you have a 90% lesion, and you maybe even just do a lifestyle change. You can watch that lesion and show that it's either stable or maybe even regressing. But certainly, knowing it's there is better than not knowing. In most of the situations, not every situation, because if there's nothing you can do, don't look. We used to have a thing like, if you're not sure what you're going to do with the results, don't do the test. But now we can do a lot of things, and so in those situations, I am a big believer in CTAs have become more and more a part of what we do. So that kind of answers, I think, a lot of the sort of things we can talk about on a short podcast. But did we forget anything? Is there anything else that we wanted to talk about today?
I think we covered quite a lot.
All right. Well, I think we're going to get back to work, you and I. It was lovely again talking to you.
As always.
I hope that our audience enjoyed it as well. And for those of you that did, please remember to like and subscribe and be with us on our next segment. And thank you so much, and tell all your friends about the Soffer Longevity Podcast. Thanks so much.